It's my great pleasure to introduce Leah Ali, who, as Geraldine has just said, is part of the future of mental health. She's a really inspiring psychiatrist who works in liaison in adult and older people's settings. Has just moved to Surrey and Borders Trust, and she's going to chair your first session. So big round of applause for Dr. Leah Ali. Welcome, Leah.
Thank you, Mike. I think Geraldine's absolutely right. The potential for digital technologies to transform the way we deliver mental health services is absolutely huge. But what we've got to realise is, to realise that potential, we have to understand how to do it. And we're very grateful to have some excellent speakers in this first session this morning who are answering exactly that question. I think Mike's just getting an extra chair for us. But I'd like to invite up the group from the Karolinska Institute. We have Professor David Matai-Cole, who's the Professor of Child and Adolescent Psychiatry at the Karolinska, and Dr. Eva Serlachius and Fabian Lenhard from the Child and Adolescent Psychiatry Centre. And they've been working on these questions which I think are uppermost in all of our minds actually at the moment. Perhaps one of the bits that you've seen very recently is the recent publications around the REACT trial and looking at how effective CBT is. I know from a frontline delivery perspective, this has already generated quite worrying conversations, frankly, from commissioners around, well, does that mean that all digital things, all online things have no efficacy? To me, it's just astounding being immersed in this world and thinking that you could even begin to think that an entire genre could be written off like this means that the work of people like Dr. Serlachius is so important to us getting that message out there that digital technologies are moving on. We are getting the evidence around efficacy, feasibility, and understanding what the opportunity is in terms of getting access to better quality services. So I'm really delighted to be able to invite them to come and tell us more about their work in terms of CBT, ICBT for children and adolescents.
Thank you. So my name is Eva Serlachius, and I will start and introduce our research program on the development and implementation of ICBT for children and adolescents. And thank you very much for inviting us and for your nice introduction. So we have focused on children and adolescents and on anxiety disorders and OCD. And anxiety and OCD are very prevalent in children and adolescents and give impairments in everyday life, both for the child and adolescent and for the whole family. And we also have an increased risk for depression, substance use, and future impairment. Though we have cognitive behavior therapy, which is an effective and recommended treatment for these disorders, the dilemma is that we have a very low accessibility to evidence-based treatment, especially in the whole country. So CBT is recommended as a first-line treatment for anxiety and OCD. And many OCD and anxiety disorder sufferers never seek help or get access to good quality CBT. And we think that the treatment barriers seem to be lack of trained therapists, especially in the rural areas, psychosocial factors, and geographical distances. So the question that we have asked is, how can we increase the availability of evidence-based psychological treatments for children and adolescents? And can internet-delivered interventions increase the availability of CBT for children and adolescents? Because there's no bound to geographic units or place of residence for ICBT, and it can be potentially time-saving. One therapist can help more patients. And we can also enhance the levels of expertise, such as from our Professor David Matai-Cole, from national competence centers, such as our research center at the Karolinska Institute. There is a very strong evidence for ICBT for adults with more than 108 RCTs in adults. However, the research on ICBT for children and adolescents is very scarce, and there is an under-researched area. In one review, there was 4 of 48 ICBT studies were for children. Paradoxically, children and adolescents, as we know, are the most active group on the internet. So with this knowledge that ICBT is effective for adults, the low availability of CBT for children and adolescents, and the promising results for children, we started a research program on the development of ICBT. So the Stockholm Child Internet Project is a collaboration between Karolinska Institute and our Child and Adolescent Mental Health Service in Stockholm, and we started 2010. We also collaborate with the Royal Technology Institute and King's College, since David has moved from London to us in Stockholm. So today we have programs, we are developing programs for anxiety disorders, for OCD, for functional gastrointestinal disorders, for non-suicidal self-harm, and for tics. And Fabian, Lenhard, my PhD student, will describe the program for OCD. And then we will discuss our programs with David. Okay, thank you.
Thank you very much. Thank you. So my name is Fabian Lenhard, and I've been working on one of our programs, which has the focus on adolescents with OCD. And I want to give you an impression how this program looks like. So when it comes to the content of our treatments, we stick to what is already evidence-based. In the case of OCD, that would be psychoeducation, exposure-based treatment, some cognitive ingredients, and relapse prevention. So we don't really change the content of the treatment. It's more the format that we are testing, the internet-based format. So when you are a patient in one hour of our trials, what you see first is the login page. So every patient has a personalized login. And when you enter the treatment, you find different slides or pages. Here we see a short text page, psychoeducative texts that explain the rationale of the treatment. We even have elements like this, which are animated short films that explain things. Working with children and adolescents, we know that they don't really like to read a lot, so we try to work with a lot of visual content. We have elements like this that are more like a form. Here the adolescent can work with an OCD circle to understand his or her problem. And this program is therapist guided, so there's always a clinician sitting on the other side who can comment on every exercise that the child or adolescent has worked with. And so this is more like a commenting, a chat kind of conversation, but it's asynchronous, so it doesn't happen at the same time, but when the patient and the therapist has time to answer. We even have a built-in message feature in this platform where the therapist and the patient can communicate with each other. This works exactly like mail, but it's inside a secure platform. The therapist view looks like this. So the therapist has a list of patients. You see how far they got. You see what they're doing. You get prompted as a therapist when there's something happening. You get a green little ring there. So you know that you have to react to something that the patient has been working with. So does it work? That's of course what we're looking into in our research projects. There's a bunch of studies going on. Some are now completed. Mostly our pilot studies. We normally start with a smaller pilot study before we do an RCT. So there are 3 pilot studies that are already published. You find the references here. And what we found is normally strong to moderate effects, significantly pre to post treatment effects. And in the two RCTs that have been completed now, we also find significant results compared with comparison group. And there are other projects that are still ongoing or in the planning. So this is like we're trying to build our evidence with a series of studies, and we're somewhere in the middle, but we get encouraging results so far. So we think this looks preliminary positive. We get effectiveness for children with anxiety disorders, adolescents with OCD, and adolescents with IBS, irritable bowel syndrome. It seems to be time-saving, and this treatment seems to be acceptable also when we talk to our patients. It seems to be acceptable and tolerable treatment format. We continue to evaluate this treatment format. The maybe two most important question is, of course, does this effectiveness, is it still effective in a real clinical environment? So we are in a research environment, so if you export this to an outpatient unit, for example, is it still effective in a setting like this? And then also the cost effectiveness aspect, of course, of this is interesting, which we are also starting now to look into other cost saving effects of this treatment, because we have shorter therapist times and even cost savings for the patients as well, because they don't have to travel. So this was just a short glimpse of what we are working with. There's a lot of projects going on. Here you also find the email addresses of the project coordinators in case you want to contact somebody. And of course, we will be around the whole day and be happy to answer questions as well. Thank you very much.
Maybe I could invite you both to join the panel over there. That'd be okay. And we've got time for a few questions. I might just kick us off with one, which, coming back to the REACT trial that we were talking about, it's really interesting to see the work that you've been doing. And it strikes me that perhaps you can offer us some insights on what we can learn from targeting therapies, and if there are particular groups where we're understanding more about the nuances of who benefits from ICBT.
Okay, I start. So this is one of the unanswered questions, I guess. So what we have planned for in our research projects is also to do predictor analysis to see which does this work for and who should not get this kind of treatment format. We do not believe that this is something for everybody. But it's a really interesting question to find out who is this most effective for. Is it the younger children? Is it the older adolescents? Is it the one who with a lot of symptoms or really moderate symptoms? So we do not really know yet. We don't have the data yet, but we hope that we will have it in the years to come.
I'd like to open up the floor for any questions. Jen's coming. She's coming. She's running. You've got a very loud voice, though. We know that we can.
I would also like to just add that it can also that we also try to test for which organization, how in the healthcare system, where will ICBT fit, and we have a demand from the rural areas, and we are currently performing a pilot study up north in Sweden, where the patients, the families, they have 4 hours to the clinic. And this is also interesting how we can enhance the leverage of our competence to the rural areas.
That's really interesting. So something about embedding things within an existing pathway and how that improves accessibility. It's really interesting. Thank you. Victoria.
So my name is Victoria from Habitat. I was really interested in what you said about the importance of multimedia content to engage young people. And I just wondered how important design was in terms of developing an internet-based product that's acceptable and young people want to use?
Yeah, I think the design process was really interesting because we are a group of psychologists and doctors collaborating with IT people and graphical designers and programmers. So and also the third party, of course, is the patients. Do they like what we're producing? So I think we have been working on a trial and error basis from the start, to be honest. But we're more and more trying to, now that we have a collaboration with the technical high school in Stockholm, we try to more have a systematic approach around this. But what we felt from the start was it's really important that it looks good, and it's a nice looking design over it, because we felt that children and adolescents, they know today what's good and what's not good when it comes to graphical design and IT design. So we try to do our best, but and we try to be in a dialogue with our patients as well and ask them.
I would like to add that we made an early decision not to go into gamification or to complicated technology development, but to focus on the competence on the disorders, so that we have a theory-driven content of our programs. This is the most important thing, not the technology. And then it should be applicable for adolescents.
Thank you. In the middle.
Lesser Wright, consultant psychiatrist. I was wondering, have you been able to look at the differences in response when you look at a history of significant trauma compared to those who don't have such a history?
That's a very interesting question. We have not systematically looked into trauma in our trials. So for what we take is like background history, and we do psychiatric screening. We use the mini kid as a screening instrument, and if we detect any PTSD, for example, we take that into account in our evaluation. Is this patient suitable for the treatment? We have not yet used it as a predictor, for example, for the outcome. I think that's a very, very interesting suggestion.
I think we've got time for just one more quick question. Lady over there. Oh, sorry.
Oh, hi. My name's Max. I'm a health economist for my sins. So we're all always interested in data and effectiveness, and what you've got on the programme that's really exciting. In the UK, it's really difficult to get past, and we're an external body, we're not within the NHS. How easy have you found it to, or could you advise us on how easy it would be for us to engage in terms of data governance, and how you've gone about anonymisation, pseudonymization, and how complex your system is compared with ours in terms of accessing data, so that we can actually get some analytics and some of the big data challenges answered?
I think that the content of I don't know if I understood your question correct, but the content of the program can easily be translated. So it's more a question of the technology, the platform.
So was your question in relation to health economics,
really, right? In terms of how easy is it in Sweden to get a collaborative approach from different players, so internal, small, medium enterprises, your health service, researchers? How easy is it for you guys to work together on the same data? It's part of the challenge we have here in the UK.
So I think it's often quite tricky for SMEs in the UK to kind of get something collaborative working with NHS partners. Would that be about right? Or have more traction probably with kind of academic partners. I think probably the question is, what is the landscape like in terms of that in Sweden? How easy is it to do that? Is that about right?
So again, the technical platform is important, so that it's safe for implementation, and yet we do not have that for children and adolescents. So we have a very big interest for collaboration, but nothing in regular health care. So we have started with the county councils that show the most interest, and this is the rural areas. And I think that together with them, we will solve this problem, because there is such a need for the increased accessibility. I don't know if I answered your question right, but
I think maybe it comes back to the point that you made earlier about embedding some of this in existing pathways, and that perhaps has made it easier to get these collaborations up and running. Would that be fair?
Yes, probably. So, so last Friday I had a meeting up north, and the director for this CAMS unit is very interested. So we discussed what can you do and what can we do, and we can enhance the leverage of our competence, our team from Stockholm, and they have the context. They can assess the children and adolescents, and together I think that we will work this through and based on the needs.
Thank you very much. I think,
so if anyone of you are interested, one of our PhD students will defend her thesis next week on our program on anxiety disorders. So I have 2 of her thesis here. Thank you very much.
Thank you very much. So our next speaker is Sefi from Xenzone, and I've learned today that Aaron's just about to start some work in my own patch in the Surrey and Borders, and it'll be really interesting to hear how you're approaching this problem of blended services, blending face-to-face services with integrating with digital technologies. And I understand you're were the head of the whole of the South. I love that title, that's amazing. Aaron, I'd like to invite you up to tell us more about your work.
Hello everyone, my name is Sefi. I'm Service Development Manager for Xenzone. Xenzone are the organisation behind Kooth, which is our digital platform. And we build all the technology ourselves, as well as providing the service in Kooth. So we're an award-winning online counselling support service. We very much come from an early intervention and prevention background. We've been operational for 11 years. We feel like the old kids on the block sometimes with this. We work with young people, 11 to 25, across 25 different areas of the UK. Predominantly commissioned by local authority, increasingly by CCGs over the last few years. Everything we do is text-based, so again, a bit of an old hat, but it's very much where young people want to communicate. It holds the anonymity of the service together, and there's lots of different good reasons for it. We're counselling, support and advice, so as I say, prevention is our main focus, and drop in and drop out, young people are able to access our service at any time, up to 10 o'clock at night, 365 days a year. We've got therapists available to talk to, and so young people can come in and out, hence the popularity, and that's where it's evolved from. We're anonymous at point of entry, and we're promoted through schools and agencies, and this is a big part of the integration aspect of how we're integrated on the ground. And we're increasingly commissioned as an integrated service, as Alice was saying, and I'll talk a bit more about that in a moment as well, how our best services are integrated into existing provision. So just a few more facts about the service. So we are a team of qualified counsellors and psychotherapists and support workers from different backgrounds, different mental health practitioners. We also offer mindfulness and more we do dialectical behaviour therapy online and face-to-face because of the predominance of self-harm that we often see coming through the service. We've got many years of face-to-face counselling experience as well that we bring to what we deliver. And we've got a great management team and clinical governance. And so we've been developing and leading an evidence base for working with children and young people online. I'll talk more about that in a moment. And we're a virtual service, but we have a key focus on the lived experience of young people and how we can integrate into that. So this is the sign-up page, how you sign up to Kooth, and we promote Kooth through schools and community settings, as I explained, and through camp services, so that young people can just come on and sign up, easy access, easy way of coming onto the service. And from the start, we've got 1 foot in their lived world as well. This is just a screenshot of our magazine because, as I say, a lot of our work is around support and prevention. So sometimes a lot of young people are just accessing, without even coming on to speak to one of our therapists, they want to use certain aspects of the site. Young people write the majority of content for the magazine, and we have media workers who also, again, integrate our service into the face-to-face world by going into schools and working with them. This is a screenshot of our peer support, which is another very big, probably the biggest aspect of what we deliver outside of the counselling. Peer support is a critical element of the service for young people to support each other. Everything's pre-moderated on here, so young people can't talk to each other directly on Kooth. It's not a social networking site, it's very much a closed system. And again, we join this up in a face-to-face way in terms of, we've got a project called joiningup.com where we go into schools and create and have group discussions with young people around mental health issues, and we bring that onto online and vice versa. And we have a lot of self-help worksheets on the site, and that's another important part of our engagement. A lot of these are co-produced with young people. So very early on, we discovered that we have different levels of interventions that we're delivering on the site and through the service. And we've got the peer support magazine and drop-in chat, which we saw as the information, advice and brief interventions. We then have the structured counselling and mental health support on a weekly basis in the traditional ways you would with a face-to-face counsellor. And we've got the high-end support as well, and this is where we work very closely with face-to-face CAMS provider to make sure that we're working in partnership with specialist CAMS, which we do increasingly. And just a bit about reaching out, really. We have, so 68% of our logins are outside office hours. Young people use us mostly at those times. And the integration of our service is critical to our success and our popularity. Typical case examples that we work with around isolation, alienation, inability to access face-to-face services. So we really have to reach out to find those young people. And I think we provide the human face of digital technology, and we're meeting the need for contact in the online world. So a bit more about integration. We believe we need to provide a seamless experience of digital support so that there is that flow between whatever a person is experiencing digitally and whatever they can get online and face-to-face. There needs to be an ease of use and access. So again, it's not just about providing something that people can have to go out and find. It's about making it really apparent in their lives and enhancing their lived experience. It needs to be embedded in that way. So in that sense, we can't stand alone effectively. And we also believe around integration of evaluation measures. So we use the CYP IAPS minimum data set online, and we use those face-to-face as well, and we're able to start doing more and more comparisons between our face-to-face services and our online services. We've been doing about 7 years of practice-based evidence and massive data collection that we've got, and we very much believe in the research coming from the ground up in how we deliver, in how we work at that. We would like to do an RCT at some point, but we're still developing a lot of the methodology for that, and we believe that's an important way of doing it. So we got a name check at the Future in Mind I wanted to show off, because it's a nice one. The Department of Health Task Force produced a Future in Mind document this year, and recognised that digital support can encourage an individual's autonomy over treatment. Online services should be commissioned in a way that is integrated and complementary to face-to-face support. So it was nice to see that being recognised, and we're starting to see that coming through in the CAMS transformation plans. More and more CCGs saying, how do we integrate this offer? This is a diagram of how we work. I'm not going to go through it, it's quite hard to do, but basically Kooth is there as part of a wider delivery and linking in with face-to-face provision, very much to reach vulnerable young people. I think that's a critical element of how we do that. And so in certain areas we have a young carers project, we have a children leaving care project, a children in care project.
so that we can work closely with face-to-face providers to make sure the most vulnerable and most needy get to use our service. And finally, I just wanted to show some blended examples that we're delivering at the moment. So in Cornwall, Powys and Knowsley, we deliver our own blended service of online and face-to-face counselling, and they've been running for some years. Nottingham, we've recently been recommissioned for a blended model of online and face-to-face counselling, coupled with a school-based DBT programme that's running very successfully. In Lincolnshire, we were commissioned alongside primary mental health workers as part of a preventative service, and that's been running very successfully for about 5 years now. In Holton, we've just recently been commissioned alongside 5 boroughs NHS Trust to provide a blended approach to their CAM service. And these are another recent ones in Devon. We've got an exciting new project called Early Help for Mental Health, where we're working in partnership with a local provider called Young Devon, who provide the face-to-face counselling, and Virgin Care, who are providing the CAM service, and they're doing some workforce development around it as well. And we've got the Kooth service embedded in there. And finally, in West Sussex, which is our newest service that's just started last month, where we're working in partnership with the YMCA. So all in all, I guess that's the flavour I wanted to give you, was of how a service can develop and evolve and become very popular as a way of once it's been integrated into existing provision. And that's it, really. So thank you for listening. And is there any questions?
Thanks, Aaron. We've got a question at the back.
Girish, I'm a psychiatrist from Sheffield. The common objection that is raised when we have mentioned online forums is about security. Now I know that you're less likely to get hacked than you're likely to lose a letter.
Yes.
But that is the commonest kind of scarecrow that is put out to say, oh, if it can't be completely secure. How did you manage to convince all those local authorities and people whom you have engaged with that actually this is as secure as anything else that we are doing in the real world?
Mainly through the way that we, because we have our own in-house IT team, so we develop all our systems ourselves. So we're able to talk at great length about the levels of security that we provide around Kooth. We work with something called Rackspace, and we have the equivalent of the American government in terms of security around our service. We pay quite a lot of money for ongoing 24-hour security around our site. And I think that's the major aspect of it. Of course, all our data is anonymized as well, so there's very little that any hacker could actually get into of any value. And I hear your argument, but I also would argue, and I do argue back to them, that I think hackers have got more interesting things to look into than our service. But yeah, thank you.
Thank you.
Mike Harris, I'm a psychiatrist. I can see the attraction for local authorities in having your service, and it spreads an apparent service very, very well, but how good is the outcome data? How do we know that it actually works and it's helping people?
That's the ongoing issue, and so we've been developing, I think about 7 years ago we did our first piece of research with the University of Manchester, where we developed an evidence base for the fact that there is a therapeutic alliance that's experienced online. Since then we've been using different outcome measures to collect data. We are in the process of working those up. We've done some small-scale projects where we can show some evidence that online counselling is effective. As I say, we're not at the point yet where we can do an RCT, where we can actually show something more concrete, but we're getting there in terms of the methodology of how we would do that in comparison, direct comparison to a face-to-face equivalent. Now we've got RCTs behind face-to-face counselling in terms of school-based counselling. We've got a direct comparison that we can do it with. So we're getting there with that, and I think think generally the popularity of the service has been such that that's why CCGs have started buying into the service, recognising the value of it across those areas. Yeah.
Fabulous. I think we've got time for one last question.
Michel Foster, Associate Professor in Computer Science, Nottingham. I was wondering, how in practice do you engage with primary and secondary care providers? In terms, do you ever share data with them? Are the people on your platform able to sort of transfer any of that? Do you ever have the need to refer? Are there any ethical considerations that you ever have where you feel you must approach a secondary care or primary care?
Oh, for sure. Yeah, and as I showed with that top end level of work that we do, that's where young people tend to lose their anonymity on our service. So that's where we get the details, we have the pathways into those services, and then our practitioners will work directly with the face-to-face, whatever it is, whether it's a specialist CAMS provider or social care. We work directly with those, and we can share those case notes with the young person's permission. Of course, the primary aspect of our service is anonymous at point of entry and is about early prevention. And so the majority of young people, we don't need to get to that point too. We can contain them. And I guess that's where we've evolved in the way that we work online, getting more sophisticated in our interventions so that we can manage a high level of risk online. And that's what we have to do, because a lot of young people who come onto the service want to stay anonymous, want to stay in our service in this way. So we have to manage those levels of risk, hence the clinical governance and the clinical involvement in all of that. But where necessary, we will work with partners, but it's always with the young person's permission, because ultimately they can close the lid and walk away if they want to.
Thank you very much.
Okay.
Thank you, Anne. So thank you very much to our speakers this morning. I think it's a great start to the conference. It's interesting to hear how things have moved on so much, even from the first MindTech conference a couple of years ago. And both of you made mention of the fact that you were basing this on existing research around existing services. But actually, I think we're starting to get into a situation where actually you're offering something quite different. And we're starting to see that it's not just about digitising existing services, you're starting to offer something completely different, and I think that's a very exciting space to be in. We have a break now until about 11:25, I think. Thank you very much.